With this, we'll move on to the second part of the program. Doug Fuller will provide fairly brief updates with respect to clinical developments in U.S. dialysis practice from our DOPPS Practice Monitor website. Doug Fuller.
Thank you, Bruce. Good afternoon, everybody. First, I'd just like to start off by thanking everybody for your interest and consumption of the DOPPS Practice Monitor. We now have 75 months worth of data available on the full website, and as Bruce mentioned, I'm going to briefly cover some highlights now. Firstly, in the area of dialysis prescription and dose, this slide looks at single pool K2 over V from August 2013 until August 2016. These data are presented every 4 months. And generally, single pool K2 over V has remained pretty stable around 1.6, fluctuating between 1.58 and 1.63. And about 6% of patients have K2 over V less than 1.2. K2 over V is notably a metric on the QIP. Next, dialysis session length has remained on average about 220 minutes per session, with 32% of patients dialyzing for less than 3.5 hours or 210 minutes, and that's up slightly over the past few years from 29% in August 2013. Likewise, there's been little change over the last several years regarding blood flow rate. Average blood flow rate is 424 mLs per minute, and just under half of patients have blood flow rate greater than 450 milliliters per minute. Moving on to anemia. This graph shows in the dark blue the proportion of patients prescribed an ESA in the prior 3 months. In orange is the proportion prescribed IV iron in the prior 3 months, and the blue and the green lines report the proportions using ESA with the subcutaneous route in non-LDOs compared to LDOs. And LDOs remain almost entirely intravenous route ESA over this time. However, there appears to have been a decline in sub-Q ESA in the non-LDOs since October, or actually declining starting toward the end of 2014. We note that the use of sub-Q ESA is typically a facility decision, with facilities opting to choose IV or sub-Q and apply that to the majority of their patients. And of course, as our sample changes over time, the sensitivity of this metric will also change over time. So currently, among non-LDOs, about 15% of patients are now using ESA through the sub-Q route. Meanwhile, the proportion getting any ESA at all in the prior 3 months has remained about 90%, 91%, and IV iron has ticked up slightly, although down in the last 3 or 4 months at 83% of patients. As we've noted in the past several web conferences, as well as DPM updates generally, the notable increase in use of darbepoetin alpha, as well as pegylated epoetin beta, also known as Mircera, continues to increase, although the increase has slowed at this point. About 15% of patients are now using darbepoetin, and 36% of patients are using pegylated epoetin beta, and epoetin alpha use is now about 50% of patients. Weekly IV epoetin dose, this is EPO alpha only, among patients who receive it IV. In the early part of the DOPPS Practice Monitor period, starting August 2010, going through August 2012, we reported a decrease in the median dose of 30% from 13,100 units down to 8,800 units, and a substantial decrease in the 90th percentile as well, from over 50,000 units to about 30,000 units per week. Over the last 3 years, This has been a very stable and flat trend. About 8,000 units per week has remained the median value, and just recently the 90th percentile value has dropped below 30,000 and now appears to be about 26,900 units per week. Notably, with the change in ESA type 2 use of more prominent use of long-acting ESAs, we've not observed a substantial difference in hemoglobin values over the last 3 years. The introduction of Mircera has been noted in the second half of 2015, and there's been very little change in hemoglobin across that time point. And the median hemoglobin has remained stable at 10.8 grams per deciliter. Ferritin values, again, as we've reported, have been increasing since 2010, with the median increasing from 605 nanograms per milliliter to 768 nanograms per milliliter, which was an increase of 27%. However, since October 2014, ferritin values have stabilized or fluctuated around a stable number, with increase only 2%, with a small 1% decrease in the mean, and the 90th percentile has decreased 6% as well. So ferritin values that had been increasing since 2010 now appear to be stabilizing and perhaps even starting to decline. Lastly, in mineral and bone disorder, calcium and phosphorus levels have not changed very much over the last 4 years. Since October 2013, total calcium levels about 9.0 to 9.1, and phosphorus levels have stayed 5.1 up to 5.3. Perhaps a small trend over time in phosphorus levels. Parathyroid hormone levels have, again, in the 2010 to 2012 period, we observed an increase from 2010 to 2011. And PTH has continued to drift up slowly since then. The increase in the median has been 7% in the last 2 years, now with the median PTH value in the United States of 370 picograms per ml and a 90th percentile value of 913. Prescription of therapies for MBD has remained fairly stable over time. We've observed a small, very gradual decline perhaps in the prescription of phosphate binders in the prior 3 months, down from 87% to 84%, and a slight dip in recovery in the proportion prescribed vitamin D. Vitamin D here includes both IV and oral drugs, active or analog forms. The proportion of patients prescribed cinacalcet in the prior 3 months has increased from 26 up to 30% over the past 4 years. We have noted previously that there's been a transition toward higher use of oral therapies of vitamin D, and that has been sustained and stabilized now, where in the orange, 30% of patients are receiving vitamin D through the oral route only, with an additional 4% receiving it in combination with IV therapies, for a total of about 34-35%. So in summary, there's been no clear changes in dialysis prescription practices since 2013 with regard to K2-over-V treatment time and blood flow rate. Mircera use has increased and stabilized at about 36% in the most recent report, with concurrent smaller increases in darbepoetin use, which is now at about 15%. Stable trends in IV EPO alpha dose, and a slight and a recent decline in subcutaneous use of ESAs in the non-LDOs. Hemoglobin values are remaining steady at 10.8 grams per deciliter. Ferritin levels remain elevated, but may be retreating. We're going to continue to update ferritin values as we can. PTH levels remain elevated, and with a median, this should say 370 in October 2016, with no clear trends in other markers, calcium and phosphorus, as well as the sustained use and substitution of oral calcitriol and cinacalcet use at 30%, and phosphate binders, a slight decline since 2013. Just a reminder again, the DOPPS Practice Monitor is based on a sample, on the DOPPS sample of dialysis units in the U.S. New trends do require external confirmation from national sources when available, and be happy to respond to any. Reminder that we do accept questions through the chat feature. While you're thinking of questions, I'm going to open up the first poll, which asks, for patients prescribed cinacalcet in your dialysis unit, what proportion discontinue within 6 months? And the options are less than 10, 10 to 20%, 20 to 30%, more than 30%, or my facility does not prescribe cinacalcet. So in response, we had 35 responses. Just over 25% responders indicated they do not prescribe cinacalcet, and among the rest of the respondents, the majority seemed to select less than 10% of patients discontinue within 6 months, with about equal numbers between 10 and 20 and 20 and 30. So, thank you for that. All right, and so the next poll question I have quickly, for the primary type of ESA used in your unit, what is the primary reason for use of that ESA? Okay, with 34 responses in so far, looks pretty close. The majority of responses were lower price and on formulary.
Right, which I think is as one might expect, and at least preliminarily our data indicate, as Doug noted, certainly that hemoglobin levels are quite stable regardless of ESA type used amongst the now 3 primary ESA types available in the U.S. So, centers are making switches, often without a lot of really based on what's available, and which ultimately is a pricing issue, of course. Doug, thank you very much for your excellent review of what's been going on. You know, we still, as Doug noted, we've not seen a lot of substantial changes in practice in recent months or even the last couple of years. We still, as the DOPPS Practice Monitor has highlighted, some areas that I think are important to be aware of include the relatively short treatment time that we still see with 30 to 35% of patients with treatment time under 3.5 hours, very high average ferritin levels, though there's a lot of variation by facility practice with respect to ferritin, some facilities tolerating or treating to much higher ferritin than others, and then the high PTH levels, as Doug has noted. This is an issue in particular in patients of African American race, for whom I think it's 30% or more that now have PTH levels above 600. Okay, so those are some areas for us to continue to follow, and also to try to over time understand associations and implications with respect to really how patients are doing clinically. We do have a question related to peritoneal dialysis data. When will those data be available? We actually will be in 2017 producing and distributing many of our baseline data from our PDOP study, peritoneal dialysis study. They will not, at this stage, they won't be available in a DOPPS Practice Monitor format. The DOPPS Practice Monitor is focused on in-center hemodialysis. We nonetheless will be able to pull together and disseminate through other mechanisms our PD-related data, and we appreciate that question and your interest. There was also a question about fistula and catheter use, whether that has changed much in the last year. Yeah, and just looking to Doug as well, just to confirm, we've not seen any substantial change. Doug? No,
I don't have the slide handy to show everybody, but obviously this is on the DOPPS Practice Monitor website. The proportion of fistulas has continued a very gradual increase over the length of the DOPPS Practice Monitor. So on a per year basis, the trend has not been very large, but.
But Doug, you're still seeing,
compared to 5 years ago, there's more fistulas.
You're still seeing some gradual increase, even now, in fistula use and concomitant reduction in catheter use. Okay, thank you. We have another question about DOPPS and monitoring of biosimilar ESAs and etacalcetide should they gain FDA approval. The biosimilars, the short answer is definitely yes. We're actually very interested in monitoring uptake of any new products in the renal space, so are well set up to do so. So we appreciate that question. The etacalcetide is an IV calcimimetic. For those of you who may or may not be aware of it, an IV calcimimetic, and recently results of several phase 3 studies were published actually just this past week. So thank you.